Hey everyone, this is your lecture on the sensory system, focusing on your ear and hearing. And the objectives of this lesson that we will be covering are the following. This section is the basic anatomy and physiology of your ear and your hearing. And please read over this just to go ahead and, revise your anatomy. Just remember you have the, external ear, the middle ear, and the inner ear. These are important sections to remember. These are some test your knowledge questions. This is a good video about auditory function. Please review it. Here's another question. Let's focus on hearing loss and disorders, right? There are different types of hearing loss. First, you have the conductive hearing loss, right? What happens in conductive loss? The sound doesn't travel well to the sound organs in the inner ear. Remember, you have the external, middle, and inner. So the sound isn't traveling properly into the inner ear. So the volume is less, but the sound is clear. The sound is clear, but it's very less. So if you raise the volume, then the hearing becomes normal, right? It's the most common disability. For example, some people, they need to raise the volume to be able to hear, but it's clear, but they just need it to be louder, right? So what the causes for that could be, impaction of wax, cerumen, right, which is your earwax, right, in the middle ear. That can be causing the sound to not travel through the middle ear into the inner ear, right? Then you can have infection, trauma, eardrum, your eardrum being perforated can also cause that. And it's usually treated by removing the wax and through hearing aids. This is the most common one. Then we have the sensory neural. This is when sound passes properly through the outer and middle ear, but it's distorted. Remember, it's not clear like conductive, right? It's distorted due to the defect in the inner ear or damage to a cranial nerve, or both, right? So it can either be damage to the, cranial nerve number 8 or defect in the inner ear, right? This can cause perceptual loss and is progressive and is on both sides, bilateral, where natural hearing loss is permanent. Neural hearing loss is permanent, sorry. This can happen because of damage to the 8th cranial nerve, infections, ototoxic drugs. We need to know what medications, the patients are taking, and trauma. It can, any damage, neuromas, noise, neuromas, high noise, like very loud noises. The aging process is usually detected with a tuning fork. Then you have a mix of conductive and sensory neural. This is profound hearing loss that encompasses both, the conductive and the sensory neural injuries. Okay, so hearing loss management. How is hearing loss managed? We want to get a good history on that patient, right? We want to know onset, duration, description of their hearing, issues. We want to see if it's bilateral or if it's unilateral. Is it just one side or is it on both ears? Did they recently have any trauma or infections, right? What medications they take, because we want to know if they're taking any ototoxic medications, right? Any childhood delays or any academic problems they had, because sometimes children have problems academically because they can't hear, right? And so then the doctor will do an otoscopic exam to check for the patency of the ears, any, earwax in there, any foreign bodies in there, infection, if there is any infection, any structural abnormalities, right? And then we call the pure tone threshold. It's an audiological test conducted with ear and bone conduction assessment to quantify hearing loss. Because remember, in healthcare, we want to quantify everything, right? Then we have speech reception threshold. We want to check, measure the intensity at which speech is recognized, right? So the treatment is we treat the cause, whatever is causing the problem. If it's earwax, if it's maybe a cockroach in the air, we want to remove the cockroach, right? Just saying. And then you want to, and tympanostomy tubes, they might place a tube in there, check, they might need hearing aids. Surgical management is the cochlear implant or the tympanoplasty, surgical reconstruction of the eardrum. Okay. So the assessment, like we said, patient history, check the current medication, observe for any hearing difficulties, assess hygiene of the ears. Are they clear? Is there, impaction of, earwax in there, right? Then you want to do a physical assessment. You want to palpate the external ear to look for any, damage, any lumps, any masses, anything like that. You want to check the size and shape and the symmetry of the ears, right? And you want to check for any swelling or thickening of the external ear, right? And then we want to check for, inability to hear things, right? And we can do this by whispering from 1 to 2 feet away and see if they hear us. Inability to, respond, if the nurse covers her mouth and indicate, this indicates lip reading, right? We want to make sure that the patient is not just reading your lip and they're actually hearing you, right? You want to check their ability to hear a watch tick from 5 inches away, right? You want to see if they're shouting while they're talking, because people who usually have, hearing problems tend to speak louder, right? Or, there's training to hear, like, are they turning their head to see, try to listen to something clearly, then check to see what side they're turning, right? If they're answering questions incorrectly or inappropriately, then there's something wrong, right? If they're raising the volume of the TV or radio too high, then that could be a hearing issue. If they're avoiding large groups because they get, too much stimulation, or they just can't hear and so they feel scared, right? Are they withdrawing from social functions or interactions? That's another sign that they might have hearing problems. So, if they're having clinical manifestation of depression. So what do we want to do? We want to reduce distractions. When we walk into the patient room and we're talking to the patient, we want to reduce distractions as much as possible. Like, turn the TV down or off. Let them know. Don't just go and turn the TV off, right? Let them know, hey, I wanted to talk to you. There's some things we need to discuss. I have your medications. Is it okay if I turn the TV down or off until, later, and then I can turn it back on before I leave, right? Or close the door to stop the outside noise. Move to a quieter location if you need to. Devote full attention to the conversation. Don't multitask, right? So, because if they already have a hearing problem and you're multitasking, they can't focus. Look and listen during the conversation. Begin with casual topics and then progress to more critical issues, because now you can, assess their ability to understand you. Don't switch topics abruptly, right? Start with the casual ones, then progress to the more critical ones and go slowly, and, maybe announce when you're about to switch to another topic. If you do not understand, let the client know. If they're human, right? Sometimes we don't understand everything they say. Just let them know, I'm sorry, I didn't understand what you said. Can you please repeat that? And sometimes you can rephrase it and see if that's what they were trying to say. If the client is a lip reader, face them directly, right? Speak slowly and distinctly. Don't hurry conversations, right? Use active listening techniques. Speak in a low-pitched voice. Even though they have a hearing problem, screaming is not going to help them. Stand in front of the client with the light source behind the client, so the light is facing you. That way they can maybe read your lips. Use visual aids if possible, like communication boards or pictures or things like that can help make the conversation goes more smoothly. Right, diagnostic studies. These are a list of diagnostic studies that are done to assess patients' hearing. You have the audiometry, tympanometry, the ENG, the CT scans or MRIs. All of these help to detect disorders in the ears. These are these two tests that we can do as nurses. One is the Weber test. This is used to distinguish between conductive or sensorineural hearing loss, right? To perform this test, you activate a tuning fork by holding the stem and striking the 2 lines with the back of the hand. Please watch the videos, in your lab course. You can place the tuning fork in the midline of the patient's skull and ask whether the tone sounds the same in both ears or better in one than the other. Then we have the Rhine test. This test compares conduction and air conduction and bone conduction. Again, the tuning fork is inactivated as described. So please read over this, and it's important for you to remember this. Common ototoxic medication. Now, we said sometimes some medications actually cause damage to hearing, right? Damage to the air. Some of these medications include certain antibiotics, right? NSAIDs, diuretics, chemotherapeutic agents, and there are other drugs as well that can cause this. So it's extremely, like if you notice here, pain relievers and such as aspirin and Tylenol can also cause this. NSAIDs like ibuprofen or naproxen, certain antibiotics like neomycin and streptomycin. So these are very common medications, even diuretics, right? So they can cause, damage to a person's hearing. These are some questions here for you. Now, just like we talked about protection of the eyes, right, and the vision, right, we want to talk about protection of noise. We want to help teach our patient to, teach them how to protect themselves from excessive noise, like wearing earplugs or earmuffs when they're in very loud environments, because extremely high pitched sounds can damage a person's ear, and especially if you have, consistent loud noises, right? And you see that in our, youngsters, and young people, and even old people. Sometimes they constantly have these, AirPods on, AirPods on and stuff like that, and the music is very loud, and that can destroy their hearing. And it's, that's why it's very important for us to teach our patients that, right? Frequent use of earbuds or listening to music and other sounds. Monitor the volume levels. Don't raise it very high, right? It's already in your ear. You don't need to raise it high. Encourage patients to wear waterproof earplugs when they're in the water, and then instruct patients to not insert foreign objects into the ear canal, such as cotton buds. Like some people, they'll use the earbuds and they like push it all the way down in the ear. The earbuds should be used to clean the external air, not the middle air and the inner air, right? Because it can rupture the eardrum and they'll lose their hearing. Or, or wax impaction can happen from that too. This over here is a chart of noise levels. Up here are the dangerous noise levels, right? These are things that can be very dangerous to a person's hearing, especially if it's prolonged periods of it or for long periods of time, every day, constant. And this is where, the threshold of hearing is, the 0, right? For example, level 10 is like a pin falling, right? Rustling leaves. And those are still fine for you. You have a refrigerator hum, a floor fan, right? A conversation is considered, 60, or air conditioning unit, when it turns on, right? That's about a 60. Then if you go up, you have a vacuum cleaner, lawnmower, you have the hand drill, the tractor, city traffic. All of this is about a 70 through a 90. Now we're getting into the really loud noises. And the more the noise levels, the decibels, the more damage that can happen to your ear, right? You have motorcycles, chainsaws, hammer drills, like a concert. You go to a concert and it's really loud, and that's actually at a level of a 100 over here. Air raid siren, right? Fireworks, jet taking off, a 12 gauge shotgun. So this gives you a good idea of, the decibels for each of these things. And as we get higher and higher, it causes more damage to the ear. So what are some age-related changes of hearing? Right? They have atrophy of the apocrine glands, and that produce your wax. So now they have less wax, right? And this causes dryness of the actual wax in their ear. And so now when it's really hard and dry, there's an increased risk of impaction, right? So people between the ages of 50 and 70 years old commonly notice difficulty with hearing, right? Both with frequencies and localized sounds. Constant exposure to loud noises in the home or at work can also increase the risk of hearing loss, like certain occupations, right? Where they're around loud noises all the time. Like if you're working at the airport, you're hearing jets take off all the time. Or if you're working at a shooting range and you're constantly hearing gunshots, So it's important to wear earmuffs and, earbuds or something just to help prevent some of that noise damage. Then we have presbycusis. It's a type of hearing loss that occurs with older adults. If you notice, I have it bolded, right? This loss is gradual and sensorineural perceptive in nature and is caused by nerve degeneration in the inner ear or auditory nerve, right? And it can affect localization of sound, especially in the presence of background noises. So they have difficulty hearing when they have a lot of background noises. They're not able to phase those noises out, right? And that's the reason why when we always say when you're, providing care to an elderly person, make sure that you minimize background noise, turning off the TV, turning it down, closing the door, anything that can help them to remove that background noise. Effective communication for hearing impaired patients, right? These are face the patient directly. When you're speaking to them, speak slowly and be attentive and enunciate, like move your lips properly so they can understand. Even if they have to lip read, at least they can understand you lip reading, right? Lower the pitch of the voice. A lot of times we think, okay, if we scream, they can hear us, No, sometimes that makes it worse. So you want to use a lower pitched voice, right? But then you want to speak, closely to them, right? Take care not to shout. Use of transparent mask. Now, if you need to wear a mask and the patient is hearing impaired, they can't even read your lips, and then you have the barrier. So, sometimes certain facilities have transparent masks, so they can actually look at your lips when you're talking. Here is some questions. So let's talk about otitis media. That's your ear infection, right? Which is very common. Inflammation and secretions cause obstruction of the eustachian tube. Often it's a viral or acute infection. Negative pressure pulls the interstitial fluid into the tube. There's a medium for bacterial growth. So it's basically a middle ear infection, otitis media, inflammation in the middle ear, right? Risk factors, anatomical, features. Presence of upper respiratory infection can cause, infection in the middle ear. History of seasonal allergies, right? Craniofacial abnormalities, genetic predisposition. Smoking in the household can cause that ear infection. Complications of these infections include chronic suppurative otitis media. They have developed a chronic infection in the ear, right? Facial nerve paralysis. Some people, we call it Bell palsy, right? So when they have an ear infection and it's in the middle ear, it can actually look like the person is having a stroke, but it's actually Bell's palsy, right? Labyrinthitis, inflammation of the labyrinth. Mastoiditis, it can cause, or petrositis can cause inflammation in all the other areas of your ear. It's important for you to go back and read the anatomy of the ear so you understand what areas this infection is happening. So the clinical manifestations that you're going to see are ear pain, tugging or pulling at the ears, trouble sleeping or laying flat, a fever, fluid or blood drainage from the ear, hearing loss or refusal to feed. Even that, you especially see that in children. They don't want to eat because the ear is hurting a lot, right? So medical management, we want to get their history. The doctor will do an otoscopic evaluation. They might be given antibiotics if it's bacterial, analgesics to help with the pain. If they have a fever, they're going to get antipyretics. And if it is caused by a viral, seasonal allergies and too much, fluid there, then they might be given a decongestant to help them dry up those secretions, right? And then antihistamines, surgical management. Then you have, tympanocentesis, myringectomy. There are different, surgical options as well if it's a very severe case. So this is a picture of what the fluid and inflammation looks like in otitis media in the ear. So nursing management, you want to check for clinical manifestations. You want to check vital signs, check the ear, tympanometry, check for age-related considerations, administer any medications that have been ordered, position the patient for comfort, treat pain and fever, right? We want to teach them about antibiotic therapy, like completing a whole course of antibiotics, medication instructions, avoid getting water in the ear, getting follow-up care. We want to do all of that. Okay, tinnitus is disorders of the outer, middle, or inner ear. It's disruption in background noise that is always present, right? May be secondary to many different disorders, right? And risk factors are advanced age, exposure to loud noises, earwax blockage, genetics, NSAIDs and antihypertensives can also cause tinnitus. So what's the clinical manifestation? Is the ringing and buzzing, roaring, clicking, whistling, hissing in the air, and that's how they'll describe it. It's like this loud ringing noise or this buzzing noise or roaring. They constantly hear that, and it's consistent, or it can be intermittent as well, depending on how bad it is, right? Medical management, you want to, check for any impacted airwax, any, osteosclerosis, any narrowing of, any in disorders of the air, vascular problems such as circulation disorders, see if they have Meniere's disease, medication, get a medication list from the patient because maybe they're taking a medication that caused it. Check for noise level exposures, what their occupation is, are they around a lot of noises? Check for damage to the eighth cranial nerve from trauma or previous surgical procedures, any presence of tumors, epilepsy, or history of seizure disorder. You want to get all of that information. You want to do physical examination, check the air out. You want to check, administer any medications that the doctor gives, like antihistamines, anticonvulsants, or anti-anxiety, or decongestants to break that, the mucus in their ears and their sinuses, and eliminate any triggers. As you can see here, this is where the tinnitus will happen. That's your internal air. You have external air. You have, impaction of airwax, middle air, osteosclerosis, vascular, circulation disorders will happen in the middle air. In the inner ear, you'll have age-related hearing loss, noise level exposure, Meniere's disease, and medications would be, the tinnitus can be in the inner ear. Then you have the retrocochlear area over there. Once again, this is the noise level that we mentioned. Sorry, going in the opposite direction. We did this. Let's talk about vertigo. Abnormalities in semicircular canals or central nervous system that can cause a spinning sensation. And vertigo can be very bad for people. It can cause them to fall and get injured, right? It's in the inner ear. It's cranial nerve number 7. Risk factors, family history of vertigo, presence of another disease such as Meniere's disease or labyrinthitis, presence of a tumor or migraine headaches can cause vertigo as well. Right? Clinical manifestation include spinning sensation, even at rest, imbalance. They have coordination imbalances, right? Lightheadedness, nausea and vomiting, and hearing loss, right? We want to get a complete comprehensive history and, about their episodes, how do they happen, what triggers them, all those things, right? We want to evaluate for other disease processes such as tumors. When you check to see what medications, they might be given medications such as diazepam, meclizine, prochlorperazine, and glycopyrrolate. These are all our medications that can help them with their nausea, their spinning sensations, and just kind of relax that, anxiety. Complications would be, of course, injury from falls, right? The spinning sensation and falls go together. Depression and anxiety, because, it's very difficult to live with vertigo. As you can see, it has that spinning sensation and it makes you dizzy. Right? Nursing management, you want to do a comprehensive assessment, check vital signs, check for balance, any diagnostic results, age-related consideration, administer any medications that were ordered, minimize the frequency and speed of position changes. Like when you're helping the patient change positions, go slow because they might start feeling, the spinning sensation. Decrease the intake of salt, nicotine, alcohol, aspartame, right? Encourage the patient to reduce stress. There are a lot of complementary and alternative therapies that are also available for patients with vertigo, right? Teach them to change positions slowly. Teach them about safety instructions. Teach them about medication and dietary compliance, like reduce your salt intake, nicotine, alcohol, aspartame, aspartame, and like their medications. Make sure they take their medications, right? So that is vertigo. Here are some more questions, and that is it for your lecture on hearing disorders. I will see you in class.